This conference will now be recorded.
I want to welcome everybody to AnCan's High Risk, Recurrent, and Advanced Cancer Group. I'm Herb Geller, and I'm the chair for tonight, and hopefully we'll be able to take care of everybody who is needing time. Now, I do notice at least one new name here in the list. It's Mr. Schultz, Samuel Schultz.
And John McPhee.
And John McPhee, okay.
We also have someone who just joined on the telephone. Would you care to identify?
Yeah, this is Tony.
Hi, Tony.
Oh, hi, Tony, how are you?
I'm doing okay. Thank you.
So, Tony, do you need any time tonight?
Yeah.
Okay. And Les, do you need any time tonight?
Yeah, maybe if there's a few minutes.
Okay. And Jerry? Jerry, do you need any time tonight?
No, I'm all right. I'm going to see my aunt Wednesday, so I'll get to you next week.
Okay. And okay, we also have Rick Ernst, who I think is if I'm not mistaken, is a new person. Is that true? What?
Rick,
According to Rick, it is, yes.
this is your first time on, right? Because you and I
Rick
corresponded today.
Uh-huh.
We can't hear you right now, even though your mic is on. You may have to authorize, you may have to tell, in your settings, you may have to set your mic.
Mm-hmm. While I'm going through the roll, John Ivory, do you have anything to share with us tonight?
Something short, yeah. Not necessarily
Okay.
tonight, but if we have time.
Well, okay. I do think we have several new people tonight. And so I think we'd like to start and welcome you to our group. We hope that participation is beneficial to you and also beneficial to us. You know, this is a group where we can share with each other and hopefully help each other move ahead. So why don't I start with John McPhee. Is your mic working?
It is now.
Okay, great. So we have a little set of questions which we'd like to share with you.
I was here last week.
Oh, you
2 weeks
were.
ago.
So right, you answered it. I thought so. That's what. So that's why I'm a little mixed up. Okay.
All right, I take responsibility. I do not recall. That's totally my fault.
Okay. So why don't we? And then so in that case, I think we have fewer new people. We have two new people here today who need to talk. Rick Ernst and Sam Schultz. And really, Pat, we would like you to share with us. So hopefully you can get your mic working. So, Mr. Rick, we have a little set of questions which we're hoping can help us guide you and guide us to a mutual discussion. So the first question is, how old are you? Rick, are you there?
So Rick, I think you're having some issues with your microphone there. It's definitely turned on. We cannot see you. You may have to authorize it at your end. In the top right-hand corner, there you go. Now we see you.
Now we see you.
But whatever you just did, you need to do the same thing for your microphone, because we can't hear you. and let's see if we can get to hear you. Use that settings and select your computer microphone. The settings is the little cogwheel in the top right-hand side.
Right. If you go,
Now can you hear me?
We can
Now we
hear
can
you.
hear you.
What did you do to
Right.
fix?
Internal microphone built in.
okay, that's
All
great.
right. Now we got you.
Now
Okay.
we got you.
And can I just say one other thing, Herb? We
Yes.
have, for the new people, we have a chat window. It's the little bubble in the top right, and there is usually a lot of action in that chat window. So keep it open and watch what's going on in the chat window, because you'll find people will put in links, thoughts, connections, goodness knows what else. Back to you, Herb.
Great. Thank you, Rick, for your guidance. So the chat window is important. So Rick, we're really welcome to our group, and maybe we can just get started with a few questions.
Okay.
First, so how old are you?
I'm 73. I'll be 74 on the 28th.
Happy birthday.
Yeah.
Yes.
I
Okay. And you live?
I live in Green Valley, Arizona. My cancer was discovered in October of 17. I was working out with a personal fitness advisor. I felt really good. The year before, my PSA was 3. And when I went for my annual visit, it was 34. And so I was
Okay.
referred to a urologist. They determined that I had metastasized bone cancer also. And I started monthly injections of Firmagon and Xgeva. And I did that for quite some time. And then they stopped that, and I'm not now taking Eligard every 6 months. And I'm choking down Xtandi tablets, which I absolutely hate. And on October 1st, I completed the Provenge immunology procedure of putting a central venous catheter in my chest and going to the Red Cross in Tucson, where they took my blood and they flew it to Seal Beach, California. And then 4 days later, it was injected into my system. It was a little bit uncomfortable. It was not bad. I don't have any side effects from that. And that was the latest thing that I have done. I feel pretty good. My energy level is about 40% of what it was before. I have some backaches once in a while, but I feel pretty good, and I'm very fortunate that I'm a cancer survivor from the year 2000, when I had tongue cancer and I was radiated for 35 times. And so I was not a candidate for radiation. I was not a candidate for chemotherapy because it had spread to other organs of my body. And so the Firmagon and the treatments that I've received so far have apparently worked. I go back on Wednesday to see my urologist, and they just gave me the Xgeva shot. But they're monitoring my PSA and my testosterone. Testosterone is down into single digits. My PSA has recently risen from 0.6 to about 3, and that was last month. So anyway, that's the kind of the short story of my treatment.
So you've had the immunotherapy with Provenge. Did you get any genetic testing done on either you or your tumor?
Yes, I did. I got the genetic testing done, and I don't. even though my father died of prostate cancer, it's not in my genes. It came back.
Uh-huh. So you have so genetically, your germline has no mutations.
Right. Yeah,
So
that's what the test showed. Yes. Yes.
did they also test the cancer? Did you ever get a biopsy and that
Oh, yeah.
sent out for genetic screening?
I don't know if they did that. I don't know.
Uh-huh. Okay. Because at some point that could be important in terms of mapping out a therapeutic strategy. Is exactly what the what are there targeted mutations in the tumor that could lead to particular therapies?
Yeah.
So it's something you might consider. So what are the questions you have for us?
I feel pretty satisfied with my treatment so far. I lead several support groups here in Green Valley, and we just finished a book called At Peace, and it's called Choosing a Good Death After a Long Life. I would recommend it to everybody. And I feel as a result of reading that book that I have a lot more agency than I did before in not getting on what Dr. Samuel Harrington calls the medical conveyor belt of treatments and treatments and treatments. And so my treatment is basically ending in right now, and I'm not going to go for any clinical trials. I'm not going to go for any heroic things that are above and beyond what's happened already. And I'm at peace with that. That's going to be okay.
So does anybody in the group have any comment or questions for Rick?
What was
Rick,
your
did you say-
Gleason score, Rick? Do you remember from?
It was 9.
Uh-huh.
That's a very aggressive cancer.
Pardon me?
Yeah, it's a very aggressive form of the cancer.
Right.
Know how many metastases you had to your bones or lymph nodes?
Well, I don't know. I don't know how to read those things, and they weren't very alarmed. They saw the metastasis on my in my tailbone and my hip, but nobody seemed to be throwing up their hands and saying you need to do something else. So I didn't pay much attention to it.
So you're still on extending?
Oh,
I was just going to ask, who's been treating you, Rick? Where have you been getting your treatments from?
I'm at the Arizona Institute of Urology in Tucson, and it's Dr. Patel. It was, he's gone now, but I mean, Dr. Patel right now.
So Rick, are you still on extendi?
Well,
hold on a minute, Peter. Let's just.
I just read the bottle today, and I've been, taking these pills since April of last year. And I just read the bottle, and I choke on these fucking pills, and I'm taking them with my breakfast, lunch, and dinner. So I'm only taking 3 a day. And I read on the bottle you're supposed to take them all at once. Well, I can't choke down those many. They're pretty large tablets. And I don't know of anybody, and I don't know many men taking Xtandi. Does anybody pay for that stuff? Nobody that I know is paying for it.
Let's go one thing at a time here.
Right. Yeah.
First of all, we'll talk about the Xtandi because there's a bunch of guys on the call who are taking Xtandi. But I think the issue that David Muslin asked is who's treating you, and if I'm not mistaken, you're still being treated by a urologist. Is that correct?
Yes, that's right.
Okay, so let's go to that one first. At the same time, I also hear you say that you don't want to do any more treatment anyway, and we have to take that into account when we when we respond to you. But let me go back to David Muslin, because I think that was the question you were looking to get answered, David.
What was the question?
David? I think the
I'm
question
sorry.
was,
Go ahead.
go ahead, David. I don't need to repeat it.
The question was who has been treating you and where are they located, and have they been your medical guide since March of or October of 17?
Yes, they have. Yeah, they
So,
were referred by my my internist, and I've been with them ever since.
so have you seen a GU oncologist at all?
No. Why?
Because,
Why would I do that?
well, the reason you do it is because the therapies that you're taking are actually not urological. They are systemic therapies that affect a lot of systems in your body, not just the cancer. And so a medical oncologist is a specialist, especially a GU medical oncologist, is a specialist in systemic therapy. And they are the ones who could really identify what are the optimum therapies for you. A urologist is a surgeon. They search.
Hey, Herb,
That's
it's Ken
training.
Anderson.
Yes, Ken. Go ahead, Ken. I'm missing. Did I miss something?
No, it's okay.
So for most of us, like me, like you, I'm also a 9-10 with Mets, and my primary physician is a GU medical oncologist, not a urologist. Does anybody else want to make a comment about that? I guess I covered.
Herb, this is
Yes.
Len. Do I have the floor?
And you do.
Thank you. I think before we even get into that, I think we need to know why Rick Ernst is no longer interested in getting treatments. I mean, you sound like a smart, stable guy who's had a good life by the book you read. And just wondering, have all of your treatments seriously impacted your quality of life? Is that why you feel like you're done with treatments, or do you feel like the only options left would damage your quality of life? What's your story there?
The latter. And the Arizona Institute of Urology has a scan of treatments, and they go from, I can get that out for you, and I'm at the end of their scan of what they can do.
Right.
So I would surmise that a urologist who is familiar with prostate cancer says this is it. And that's why I'm comfortable with knowing that this is the end of treatment.
So Rick, let me answer that. Prostate cancer is a very complicated disease with a large span. And urologists are qualified to treat prostate cancer only up to a certain point. Now, a lot of urologists don't want to admit that because they would like to treat the disease for a lot longer than they're qualified to do. Urologists are surgeons. As you know, surgeons are trained differently to people trained in internal medicine. And the type of doctor that you need to be seeing now for your prostate cancer is no longer a surgeon. Once your disease was treated initially, in fact, you didn't mention, did you get surgery initially?
No.
You should never have been with a urologist. The urologist was the wrong doctor for you from the beginning. The doctor for you from the beginning was a medical oncologist specializing in prostate cancer, what we refer to as a GU medonc. GU stands for genitourinary medical oncologist, because that is the area that specializes in the prostate. So when you say, well, the urologist knows, no, the urologist doesn't know. And the treatment that you got at the outset may even have been incorrect, depending on how much metastasis you had. It's debatable. Now we can look back. It's water under the bridge, but you've done pretty well with it. But the fact is that there is a lot more beyond the Provenge that can be done. A lot more. You just have to have the right doctor. Now, there are two men on this call. One man who lives a little north of you in Marana. And there's another gent who lives down in Mexico but gets treated up here. And they may want to talk to you briefly, or you may want to talk to them offline about what sort of doctors they're seeing. And at least one of them was diagnosed de novo metastatic as you were. His PSA was around 2,000 or 3,000 at the time. So I guess what we're telling you is that yes, the Provenge is great and we hope it helps you and it's the right time to get it, but there are a lot more treatments. You may be at the end of the road at Arizona Urology, but you're not at the end of the road for treatment. So that's something you just have to figure out.
And I think, you know, there are many men on this call who would say there are lots. I mean, one of the introductions that I sent out for this meeting was basically when I met up with my medical oncologist and at the initial diagnosis, I was very devastated. But her attitude was, look, we want to turn this into a chronic disease. This is not the end of the road. And I think that is an attitude that if you were told that this is the end of the road, I think it's time to find somebody who will say, wait a minute, there's lots of stuff out there. That's
No, let me be clear. Nobody has told me it's the end of the road. That is my judgment based on what I know about my disease.
Okay. From my personal point of view, and I think from my knowledge, there's lots of other things beyond what you've been getting that can treat your disease. They will not be necessarily known to a urologist.
And you're talking about oncology. You're talking about
a GU medical oncologist is the person who ought to be in charge of your case. That they are the people who are best suited to systemic disease. So, does anybody else? I think, Rick. I mean, how else can we guide you? I think one thing we can do is if you listen a little bit, you can hear cases like yours of people who have been around for many years who have had many different therapies.
I have a comment about this.
Jeff, go ahead.
Well, I thought he said he was 73 and his father died of cancer, prostate cancer. Same with me. As it turns out, same age, same father dying. But as it turns out, my mother's side was why I got prostate cancer, not my father's. But I've had it over 10 years. I'm now on my fourth set of treatments. My PSA has been above 6. It's now a little over 1. It is worth pursuing. I was told about 12 years ago I might have it. I didn't know how long I would live. It's been 12 years since then. Give it a chance. Then what they say about, I'm with Kaiser. I had a urologist who started. As soon as I had the second phase, they switched me over to a urologist who specializes in, as they talk about, in cancer. And it's totally different treatments. You've got to find out what you really need to have done.
Yeah, an oncologist, I think you meant to say, Jeff.
Well, Jeff, you say you've had several different treatments. What are the treatments?
Well, I had surgery. and then it came back a couple years later. Then I had radiation. It came back a couple years later. Then I had Lupron, and then it came back, and I started another drug, and then now I'm on another drug because it came back again. I was on biclutamide as long as Lupron, and it might be the fifth of it, but there are other options. So you need to take a look at what's available to you. And you definitely, without any question, are not speaking to the right person. My urologist, I don't even talk to him anymore. He doesn't even do my test. The oncology urologist, who's the specialist in this, and she's the only one I talk about. I mean, I've spoken to her on the phone in the last 2 weeks a couple of times since I just started taking Abby, another drug when you first start having metastasis. So it's, you know.
So let me cut in, Jeff.
I'm gonna cut out.
A couple of no, because your point is really well taken, Rick. Couple of things. One is with the type of radiation that we use today, you may be a very good candidate to still have your prostate radiated with targeted radiation that is directly restricted to the prostate. 5 years ago, they never did this. Today, there are men on this call who will tell you that they were diagnosed de novo metastatic and they're getting radiation to treat their prostate, including our chair today, Herb Geller.
Right, tomorrow morning is my third treatment.
So he's getting his third treatment. Now, I know you had a lot, we heard you had a lot of IMRT back in 2000, but there is different types of radiation today, so you may be a candidate. That's the first thing. The second thing is you should, if it were me, I would want to put a medical oncologist on my team. And Dennis Correa and Jerry Pelfrey can talk to you about who they see. Unfortunately, there's no longer anybody qualified in Tucson. And we've been through this a lot of times. But there are some very good options in Phoenix, some very good options. At least 2 or 3 oncologists in Phoenix who we would recommend. Dr. Singh, Dr. Bryce, and there's a lady too, but I would see the Dr. Singh or Dr. Bryce, both of whom are at Mayo. But we can help you and we can guide you. And I think Dennis Correa, if maybe you and Rick can exchange telephone numbers.
Yes. Yeah, I think we've got your email address, and I think what we'd like to do is continue this in offline, because I think we have to move on a little bit to other people. We have some other new men tonight that I think would like to get some time. And but I think that we definitely think that there are lots of other options for you that are not onerous, that can keep you around for quite some time.
This is Alan. I'd like to make one last comment to that gentleman. On this prostate cancer is unlike many other diseases in that, you know, you might get lucky, have one treatment, and you're cured for the rest of your life. But as a lot of the people that you're seeing tonight can attest, more likely, it's better to think of it as a journey. And you're on the journey, and you're going to take all different kinds of treatments and approaches throughout maybe the rest of your life. And it's just the nature of this type of disease. And so, you know, don't most people come into it, one treatment and I'm going to be done. Well, in this case, you're not done and you're just starting the journey.
Thanks, Alan. So I think we have to move on because we have 2 other new men here tonight. We have Samuel Schultz, and if I'm not mistaken, Billy, are you new to our group?
Yes, I am. I was in a group about a month or 2 ago, but I don't know if it's the same people or completely different, but I assume that I'm new.
And Samuel Schultz.
To this group.
Is this the first time with us? Mr. Schultz.
I don't know if my speaker's working or not.
It is.
My microphone, okay.
Hey, as far as radiation goes, they tell you you've had your lifetime amount of radiation. That's in that area. You can have radiation in another area that is not lifetime over your whole body. So check with your doctor.
So, Mr. Schultz, you there?
Yeah, I'm here. Yeah.
So this is your first time with us, as far as I know.
Yes, it is.
So welcome. And I think you heard the discussion we've had just now. So I'm going to really ask you to go through the same set of questions so we can help a little bit. So if you tell us how
All right.
old you are.
I'm 75. I'll be 76 next month.
Just like me. So, and where do you live?
I'm in Southern California in Orange County.
Mm-hmm. And
I live in an unincorporated part of Orange County.
So tell us about when your cancer was first diagnosed and how you found out about it.
I was diagnosed in 2009. I had radical prostatectomy in January of 2010. And my PSA did not go to 0. So I had salvage radiation in November of 2010. And in 2018, my PSA started rising. It was undetectable for like almost 9 years. And in 2018, it started rising, and I started on Lupron 18 months ago, and my PSA is undetectable, and my testosterone is undetectable.
So that's great. So, and what was your Gleason score initially?
7. It was 3-4.
Mm-hmm. So currently you're on Lupron alone.
Yes.
And your PSA is undetectable.
Yes.
That's great. So I guess the next question is, do you have any questions for us?
Well, everything that I've read and heard is that earlier intervention results in better outcomes. And my oncologist was hesitant to even let me start Lupron. He said it was too early. He wanted my PSA went from undetectable, and it went from around 3.31 to 4.14 in about 3 months. And my oncologist he said, let's wait till it gets to around 10. I said, I don't really want to wait.
So who is your oncologist?
Dr. Rao, Amal
and where
Rao.
Is he?
He's
and where is he located?
He's in Laguna Hills, California.
And
which is
he a specialist in prostate or GU oncology?
Yes, he is. He's with Orange County Blood and Cancer Center.
Mm-hmm. But he would have let your PSA go to 10.
Yes.
But you didn't let. But who made the decision about Lupron?
I guess we made it together because that was the first treatment.
Mm-hmm. So how do you feel? But now that your PSA is low, what do you think you can do next?
Well, I was wondering, I've heard that there are other drugs that can be administered at the same time that Lupron is administered, that Lupron shuts down the production of testosterone, but there are other drugs that block the uptake of testosterone, and I'm wondering if I should combine some other drug regimens with the Lupron, and when should I do that? Should I do that now? Usually what happens is that they wait until Lupron doesn't work anymore, and then they add this other regimen of drugs along with Lupron. And I'm wondering, would there be a better outcome if I started those other drugs now?
So maybe Len, do you have any comments?
Yeah. You know, if you were in the high risk Gleason category of 8, 9, or 10, I would advise you to take one of those androgen receptor blockers, because they've been proven to prevent or to delay the time to metastatic disease. Being that you're an intermediate risk Gleason 7, I think I might suggest, well, of course, talk to your doctor, but you might be better off just staying on Lupron since you're undetectable, and wait for the PSA to begin to rise, and then you can add the second line anti-androgen.
So I have a question, Mr. Schultz. When your PSA began to rise, and it went from 0.31 to 4.1, did you get any scans?
You know, I participated in a study with gallium-68 PSMA PET CT scan, and my PSA was, you know, pretty low at that time, and so that gallium radioactive isotope was unable to detect if I had any metastases.
What was the level when you got the PSMA? When you got the gallium-68 PSMA, what was the level?
It was like 0.3.
Yeah, I mean,
maybe even lower than that.
Right, and so you were probably scanned to where did you get that scan, at UCLA or UCSD?
Yes, UCLA.
Yeah. So, you know, it's quite likely that it was too low. I mean, I think the first thing I would do, if it were me, is I'd like to know if I have any Mets. And it's going to be hard now, given that you've driven your testosterone and your PSA down, to see. You know, probably when you were at 4.1, that was the time to do it. The other, you know, I think what I would also do, whilst Dr. Patel may be he may handle the prostate cancer in that particular office. I wonder to what extent he is a specialized prostate cancer doc, because there aren't that many around. You happen to have a couple of good people close, and it may make sense. I think if it were me, I might go down to UCSD and get an appointment with Rana Mackay, who is really great, and she's a good person. She's not just a good doc, smart doc. She's a good person. And I might want to go see Rana Mackay and say, Dr. Mackay, what do you think? Do you think I should stay on Lupron? Len has a good point. But at the same time, there are a lot of men we know who were only 4+3 at the outset. Were you 4+3 or 3+4?
I was 3+4.
Well, you know, I think Len's point is even better. So I would say, look, I'm 3+4. Would you add anything right now? The way we go ahead,
I mean, the one thing I do notice that Dr. Rao is in fact not a GU oncologist. He may be the person treating GU in that group in Laguna, but I think your situation and all of our situations demand that we find somebody, and Rick just mentions excellent people near to you.
All right.
So I think.
Yeah, can you give me those names again?
Well, one of them, I'll put it in the chat window for you. One of them is Rana Mackay. Rana Mackay, she's at UCSD, and she's really good. Oops, I sent that just to Len, and I meant to send it to everybody. Sorry. I'll send it to Pace, and I'll send that to you right now. Should be in the chat window right now, Rana Mackay.
Yeah, I see it.
There's another guy, I don't want to, we just ran across somebody who uses him. He certainly has a good background. Agus, AGUS, who's at USC, who is also a prostate cancer specialist, David Agus. I don't know, I'd have to look and see who the right person is for you at UCLA. But if you need a name at UCLA, we can definitely come up with one at UCLA. But if you note, City of Hope is another option, because you can cut across on, isn't it 55 that goes up to 210 there? Your knowledge of Orange County to San Gabriel is better than mine.
Yeah, the 57. The 55 ends at the 91.
Yeah. Sorry. Okay, but not bad, eh? So you can go over to Duarte, to City of Hope,
Right?
And you can see Tanya Dorf, who's terrific.
Oh, I actually had an appointment with her.
Okay, I mean that's another really good name for you, Tanya Dorf. But you know her. Tell us what happened.
Well, I had an appointment with her, but actually she was running a clinical trial that I was interested in. That was I forget what the clinical trial was, but I had a conversation with her office, and I didn't meet the criteria to be enrolled in that clinical trial.
Right. But she is someone who can treat you as a patient outside of a clinical trial.
Yeah. I just since I have an HMO, I just have to get approval from United Healthcare to go see her.
Yeah, I think that, you'll find, I'm not going to poll everybody on this screen, but I think you'll find universal agreement that being treated by a GU oncologist is really the only way to go forward, because they're going to have much more experience than the person that's treating you right now.
All right. Good advice.
So I think you should try that and obviously, we'd like to hear from you as things go along about how things are going, but I think we're going to try to move on. We have several new guys tonight, and unfortunately,
let me just ask a couple of quick questions. Do we have your email address, Sam?
When I signed up, I signed up online, so I'm sure that you do, because you sent me the link. You sent me the link to this meeting.
Yeah, we got you. Then that's fine. We know you'll keep getting these notices and keep coming back, and we'll keep guiding you. And I just want to make sure that Rick, Ernst, and Dennis Correa have exchanged details so that Rick can get hold of Dennis. Rick, do you have Dennis Correa's information?
Yeah, what he wrote in the chat, you mean? Yes.
Great, excellent.
Good.
Thank you.
Great. So unfortunately, we have two more new people on the call, and I think one of the things we've said in our new incarnations, in order to give time to some of the guys, we can only deal with 3 in one session. So Billy, I hope you can profit from listening to what we're doing tonight, and join us again next Tuesday, when we'll be happy to go forward with you. But in the meantime,
I just came on to listen.
No, well, I hope we can participate and help, but I think we're going to run out of time tonight if we don't move this along. So, Pat, if your mic is working, we'd like to hear from you.
I think it's working, is it?
It's working, yes.
I'd like to say the same thing that I said to my father in 1987 when he was diagnosed with PC. Get to the biggest, the best cancer center. Not a urologist, not a doctor, not a general practitioner, cancer center. That's the same advice I took myself. 2014, when my urologist diagnosed me as Gleason 10, I immediately contacted Fred Hutchinson up in Seattle, and they said, "We get you 10s right in." Anyway, so I've been treated up.
How old are you, Pat?
Excuse
How
me?
old are you? How old are you?
I'm 70 right now. And so I was 63 when I was diagnosed.
Right. And then you live near Seattle?
I'm sorry?
You live near Seattle?
I do. I live about 150 miles from it. And I had a prostatectomy in November, and then I started Lupron January, February after that for about a year and a half. I had a vacation from it, and then I rising PSA, and they could feel some nodules in my pelvis, so they radiated.
So what was your original, when you were diagnosed, what was your PSA?
It was low. It was 15. And that was after he gave me a DRE and realized it was as hard as his countertop. And he says, well, you need to go get a PSA. Not the ideal progression, but PSA of about 15.
And then after the radical prostatectomy and Lupron, what was your PSA?
It dropped to 0. Undetectable, less than 0.3.
And what is it now?
Right now, my last Lupron shot was in September 2019. My PSA was undetectable in March of 2020, and it's risen to 0.59 in December. And it's it's a doubling rate of about 2.1 months. And so when I go back up in March, we'll discuss avenues of treatment. So, and I was on Lupron and Zytiga, or it worked out to 28 months, 29 months, something like that.
And that was really keeping your PSA very low.
Oh yeah, undetectable.
So what do you think you want to do next?
Well, I wouldn't mind even going back on ADT. I don't like the side effects, but as long as it's working, I wouldn't mind doing that. He talked about getting a scan. I anticipate my PSA will be somewhere around 1.7 to 2.0 in March. And so that I would be eligible for a PSMA. I think he's waiting for them to get approved up in the University of Washington Med Center. And so they could perform the.
So have you had any genetic testing done?
Even though my father had it and I have it, it's not in my genes.
And what about the cancer?
No, I don't think they've tested that.
At some point, it could be useful. I think people can speak to that. But I certainly would think that if you had responded to ADT and Zytiga, then I think if it were me, I'd go back as soon as I could. I don't think I'd wait till March.
Yeah,
Does
I don't know.
anybody else have any comment about that, Len?
I think I might be willing to wait until he could be scanned with the PSMA scan to find out exactly where the lesions are. I don't think there's too much danger in waiting for the PSA to rise to, what did you say, 1.5, Pat?
Yeah, it'd be about 1.5, 2.0 by March. Now, I did see another.
you know, it's going to be galloping away at 1.5. As long as you can get it scheduled in advance, make sure you don't have to wait a long time to get the scan.
Yeah. I've got another major prostate center 50 miles south of me in Portland, OSHU, the Phil Knight Prostate Cancer Center. So, and I'm talking to a cancer center in Vancouver, who it so happens that the oncologist was my oncologist in Seattle, his professor at Johns Hopkins. So I'm in good hands anywhere I go.
You certainly are. So does anybody else have any comments to?
I just wanted to ask, I think, Herb, you had a good suggestion there that he should have his somatic tumor tested for, for genetic mutations. Have you had any biopsies recently, Pat?
Not since they did the my biopsy, and then after my surgery, they looked at it.
Which was 2014.
Yeah.
Pat,
so,
do you know if you have any metastasis?
Well, I did when they took it out. My lymph nodes were bad. My bladder neck was dirty, and I'm growing prostate. So somewhere along the line, I'm trying to grow a new prostate.
So when they did the RP, you had issues with the bladder neck and you had issues in the lymph nodes. But since then, we don't know if there's any further spread.
We don't for sure.
Right.
Other than the rise of
in order to really do a meaningful somatic genomic analysis, we would need a current sample. So the first thing we'd have to do is to establish where the cancer was. I mean, what I heard was that it's moving pretty slowly at this point. Did you say from 320 to 1220, it went from undetectable to what level in 1220?
In 1220, 0.59.
That's what I had 0.69. So it's moving very, very slowly. And right now you're not on treatment, correct?
No, I'm clean. I'm having a vacation, loving it.
So, I mean, Len, Len and Peter, Len especially, you're the vacation expert. What did you let your PSA rise to before you intervened? Because you've done it a couple of times, and now you're on your third holiday, kinda.
Yeah, well, I waited longer than I wanted to because at the time my PSA started rising. The PSMA test hadn't been FDA approved, so I had to get into a clinical trial at the NIH, and they had issues with supply. So I had to wait 6 or 7 months before I got into the trial. And at that point, my PSA was 2.4. I would not want you to wait quite that long. 1.5 might be certainly PSMA scans can pick up lesions at a PSA of 1.5.
So what would you have been comfortable with intervening in the ideal world?
Well, I was, when I first applied to the NIH for the trial, I was at 1.2.
1.2. And the time before, when you were on intermittent, what did you let it rise to?
Oh, the very first time, my oncologist let it rise to 10.9. That was at Sloan Kettering too.
Right. So Pat, it seems I think clearly the next step is to get a scan and figure out where it is, and then decide what the next treatment would be.
Another scan. Go ahead.
Pat, this is Peter. Have you thought about going down to San Francisco
for a scan rather than waiting for the scan to come to Washington. Yeah, I didn't know if I had to be referred to them and what the procedure on that was really. Your doctor at Hutch could probably, get that going for you.
Yeah.
And you can,
Right.
and your scan, in my situation, especially since you're off of ADT, that's the ideal time to do a PSMA scan. I never let my PSA get above 1 when I was scanned with a PSMA scan, and then I went back on ADT. But I was looking at the doubling time rather than the absolute number. Yeah, my doubling time, according to the nomogram on Memorial Sloan, is 2.1 months. Yeah, that's the time to get a scan and check out what's going on. 2.1, anything under 3 months is a red flag. Okay, very good.
Who is your doc? Who is your doc at Hutch, Pat?
Dr. Schweitzer.
Okay.
Dr. Schweitzer. My original uro-onc was Dr. Lin.
Right. No, I mean, I know of Schweitzer. He's a pretty reputable guy.
He's very. And then
So
the oncologist I'm seeing in Vancouver, Washington, is Dr. Cosgrove.
Okay, him I don't know, but I do know Schweitzer at Hutch.
So Pat, I think really we'd invite you to continue along with us until you decide to get some more results and participate in our group.
You're not
Because
going
I
to get
think-
rid of me.
Good. We're glad to hear that. But I do think we have to move on tonight because there are a bunch of guys who would like some time, and I think we should give them. But I do want to call the roll. I've got many of you, but there are some people that arrived later that I want to make sure that we need, if you'd like some time. So Ben, would you like some time tonight? Is Ben?
If time permits, yeah, but it's not an urgent question.
Okay. Bill Franklin?
No, I'm good, thanks.
Like some, okay. John A., would you like some time tonight?
Oh, thank you, Herb.
Okay. Larry, I know you were late, but I'll call your name anyway. Would you like some time tonight? Is Larry still with us?
Just left.
Maybe, huh?
Just left.
What? He left. Okay.
He left.
Larry left. Fine. So, and the Hoovers, Regina and Russ, would you like some time tonight? One of you, please unmute.
Hi, this is Regina. I'm fine, thank you.
Russ, you're fine too.
Yep, I'm fine too. Thank you.
Good. And Sylvester, how about you?
No, thank you.
Okay. I think we've now, is there anybody I missed?
Dennis
Yes.
McGuire.
Yeah, you missed me too, Herb.
Oh, sorry, Dennis.
Yeah. Hey, Herb. I'm on the phone tonight. Yeah, I'd like, if there's time, I'd like to give an update. Thanks.
Sure. I'm sorry. Is there anybody else I missed?
Just me. I just wanted to, it's Ken Anderson. I just wanted to say Dr. Cosgrove is a good guy, so you're in good hands with him.
Oh, yeah. I did miss you, Ken, and I'm sorry.
No worries at all.
Okay, so why don't we go down? Ben, why don't you tell us what's going on?
So this is a question I don't have to worry about for a while, and it's kind of a grim one. My urologist mentioned in passing something very unhelpful that has haunted me. He said, you don't want to die of prostate cancer. And well, I don't want to die of anything, but it has, I know it can be delayed for a long time, but the end game, I'm wondering what kind of death it actually is. We've seen some people who've passed away due to it, whether it's an agonizing, drawn out, painful thing, whether it's a rapid thing.
I certainly can't address it. Is there anybody else who can?
I can. My father died of it.
Uh-huh.
And he
I'm
was
sorry.
in a lot of pain from bone cancer for quite a few months before he died. So it's at least that's what I know of him, and it really makes me look forward to the fact that my first metastasis was just found in my bones. So that's all I got to say.
I would have to agree with your oncologist, Ben, your GU med onc. Unfortunately, in the 13 years I've been doing this, I've seen way too many people go through end-stage prostate cancer, and I have frequently said in this group, the prostate, exactly what your oncologist said, this is not something that you really want to die from, and therefore you should do the very best that you can to manage the disease, and hopefully something else will take you. It is not an easy death. It's very painful, as Jeff Marchi said, the bone metastasis is painful, and as the organs start to fail, it's difficult. What can I say? But I guess, you asked, we have to be honest, and that is the answer, and this is why we strongly encourage people to intervene to get the best treatment and to manage their disease for the longest possible time that they can. And there are some of us on this call, certainly Len and Peter, who have seen the disease take guys that we got pretty close to. I don't know if Len or Peter would like to address that, or anybody else on the call.
Yeah, it's bad enough that almost everyone I know of ends up on morphine or that's how they spend the rest of their end stage is on morphine or drugs such as that under hospice care because there's too much pain involved.
Peter, how long does that take?
It depends, but usually, I mean, most people I know 2 months, maybe 3 months at the end there. I mean, we've had people who had pain injection stuff and, get carried on longer, but toward the end, it doesn't take too long.
So, Ben, like you said, it's kind of a grim question, right? So my father didn't die of prostate cancer. He died of something else, but it was a painful way to go. But as Rick said and Peter said, hospice is something that those of us that if we get to that point, they can help us, right? So it helped my father immensely. And it's not just, hospice is not just you go in and you die, right? It's you go in, they take care of you, they try to get you as comfortable as possible. They try to make sure you're pain-free and that the last part of your life is, not that terrible, horrible, painful thing that this disease could be if you didn't have hospice type treatments. So it's grim to be thinking about, but also don't let it dwell in your mind that I'm gonna die a painful death, right? So that's not necessarily true. And as Rick said, you manage your disease. There's always new there's always new stuff coming out. Stay on top of it. If you want to fight, fight.
Right.
So. I'm kind of appreciative. I mean, I'm not glad to hear these answers, but I'm glad Ben asked a question. There's a couple of questions that I have never asked. That was one of them, and the other one is, how long am I going to last? And we are so oriented in, I don't know, treatment, trying to make the quality of our lives good. And we don't think too much about that, but in the back of my mind, I'm thinking about that. So I'm glad Ben brought this up. And I think this kind of like the reassurance that Bill gave as well, how we'll be taken care of.
I mean, I think this may be a more appropriate discussion for a different group. Wouldn't you say, Rick? the free discussion group?
No, and I'll say,
No?
let me tell you why. The reason why is because our Speaking Freely group, it's certainly a discussion we could have in our Speaking Freely group, but our Speaking Freely group is a pan-cancer group. And I do feel that whilst it can be, and I'll let Rusty give a quick commercial for the Speaking Freely group before we move on to the next person. We'll give Rusty a minute to do a commercial for Speaking Freely. But let me just finish. The reason I think it's appropriate to this group is because I believe that the nature of prostate cancer, end-stage prostate cancer, is not well understood by most prostate cancer patients. And part of the education is the comment that Ben's doc said to him. And I think all prostate cancer patients should understand that it's a very, very difficult end. And that may also influence their own decisions. It may influence their end-of-life decisions. It may influence how they want to prepare, if they want to make themselves eligible for death with dignity. Because you can't be making those decisions when you're in a lot of pain. And I feel that it's a very valid discussion to have on this group. And we can pick it up at any time, but we don't for obvious reasons. I also am very grateful to Ben that he raised it.
Yes.
I have a quick comment, Herb, because I was reflecting on this just the other day. You know, a couple of years ago in our group, in our advanced group, we used to lose somebody almost every month. And it was kind of pulling me apart a little bit. But this past year and a half, there's very few guys that have succumbed to prostate cancer in our group. And I think it's a big change in the way guys are managing this thing and working as their own advocate, not just relying on doctors to do the next thing to save us. It's remarkable, actually, how many of us keep going for years now and stay pretty vibrant and healthy and take responsibility. I can't think of the last person who left our group for that in that way.
Well, I would just say to you, take a look at our in memoriam for 2020.
Right.
And we lost 1, 2, 3, 4, 5, 6, 7, 8 men. And amongst those men were your friend Jim James,
right?
Who didn't have who had a difficult end. So as much as I'd like to agree with you, Dr. Rex, who didn't have an easy time, as much as I'd like to agree with you, I would say that that the evidence doesn't bear it out, Peter. I'd like to be rosy, but I'm afraid we cannot. And especially now that we're seeing younger men succumb because they get diagnosed de novo metastatic. We're seeing so many more men get diagnosed de novo metastatic than we ever used to.
Well, thanks. I think we really do need to move on.
Oh, before we do, I wanted to thank everybody for their comments. Thank you very much. Bill, Rick.
Carl, you're next.
Okay. I had to check my calendar from when we all spoke, or when I spoke last Tuesday night. It was right after I had my appointment with a telemed appointment with a radiation oncologist who made a recommendation, and I got some really good feedback from the group, and I took the advice to say that I do have a second opinion scheduled for tomorrow with another radiation oncologist to see their thought. But in addition, the next day, I had an appointment with my medical oncologist, which was after the call. And we spoke about the fact that if I should start radiation treatment, I may not be eligible for certain very promising trials that are coming out in the not too distant future, and that I should follow up with Mark Stein at Columbia Presbyterian and Scott Tagawa at Weill Cornell, which I am doing, and I do have telemed appointments with both of them on this Wednesday and Thursday to find out what trials they have, and if indeed it might disqualify me if I should have radiation from those trials. I also have been communicating with Alan, Tall Alan, and he had answered a question that I posted on the MailCare site, where is radiation palliative, if nothing else? And his opinion was, yeah, that pretty much radiation is palliative. So I have 2 spots which were identified through an axonal scan as well as a PSMA scan via a clinical trial. One in the bone marrow in the right femur, and one in the soft tissue by the 7th rib in the chest back area. The radiologist who performed the axonal scan had said, more than likely, that's why your PSA is rising. It's up to 1.98, relatively low number, but having had been undetectable for a year and 9 months on olaparib, and now up to 1.98 within a few relatively short months, it's been accelerating and has been somewhat concerning to me. So at this point, I still have things that I need to follow up on. I kind of feel like I'm in between a rock and a hard place. I really wanted to proceed, if it made sense, with the radiation, get rid of those 2 spots and zap them, and follow up with whatever additional systemic therapy was recommended. The radiation oncologist I had met with last week that we talked about, he had mentioned a follow-up with Xofigo after having 2 weeks of 10 radiation sessions, and he did not specify whether it was SBRT or IMRT, but it's assumed that it's probably not SBRT because it is 10 sessions within a matter of 2 weeks. So I will bring up those questions.
That may be SBRT.
Oh, okay.
But I think, I think the issue that keeps coming up, Carl, is what about systemic therapy? Period. I mean, is that something your medical oncologist is considering?
Yes, he mentioned going on to chemo at some point, and he mentioned one other type of treatment which escapes me at the moment.
Hey, Carl, it's Ken Anderson. I just wanted to let you know that most of the clinical trials at the moment in regards to chemo only require that you're off chemo for 28 days prior to the trial starting. So I don't think you have to worry about that prohibiting future clinical trials.
Right, and the question really right now is whether radiation would also possibly disqualify me, but I'll find out in the next 2 days.
There again, it's also only disqualifying within proximity to the trial, at least the ones I've looked at. It's not, it's very rarely permanently disqualifying.
Well, with the radionuclides, it might be more tricky.
Maybe, right. So
with the radionuclides, it might be more tricky. But I think the issue, Carl, is that we hear you that you're not keen on chemo. For the past 2 or 3 years, ever since we met you, you've sort of avoided it. But it is a very viable treatment, and you do recover. Just look at, oh, Peter Kafka stepped away just when I wanted you to look at his very full head of hair. But when he comes back into the screen, just look at that head of hair that he's got right now. And
And look at Jake's head of hair.
yeah, well, because Jake's
Look
still
at
in
Jake.
treatment. That's because Jake's still in treatment, Carl. My point is, you can't. It comes back, and you
Right,
recover.
I looked like Jake a while ago.
Right. So I know people don't, any ABC men, anything but chemo. But if I had your disease, I would be treating it systemically. We keep telling you spot radiation does not treat you systemically other than the degree to which there's an abscopal effect, which Alan is probably better qualified to opine on than any of us here, but there may be an abscopal effect, but it's marginal. So yes, as we've told you, it is palliative, and yes, it will drive it down, but then it's going to come up in another place. And until you get a systemic treatment, whether it's chemo, whether it's a bite therapy, but you're probably at the right time that you've got to consider chemo. Then the question is what chemo? Because with a PARP mutation, with a BRCA mutation, you may not be best suited to say docetaxel alone. And that's for your, was the med-onc you saw this week your guy at New Jersey Cancer Institute? I forget his name.
Soraya, yes.
Soraya, right. So, Soraya's going to decide with you, and you can ask some of the guys here what the best treatment is. I mean, Peter did docetaxel and carboplatin. Peter, show him that head of hair that you've got now. So we love it. He looks like a beetle.
Right.
Peter, did you move to Alaska? Why are you wearing a heavy?
We're getting flash floods here. I was going out to see if my back patio sump pump is working.
It must be down to like 70.
I mean,
Lynn, don't worry, it's 80 degrees.
It's raining 2 inches an hour here.
Must be down to 75 degrees. That's why you got the jacket on.
It's cold. I've got the sweatshirt on too.
Yeah,
thank you. So Carl, I think, you're meeting with your radiation oncologist, you're meeting with your GU oncologist. I really think you ought to have a heart-to-heart about what's going to be the long-term success here. And I agree with Rick. I mean, I went through chemo. It wasn't fun, but I've got my hair back and I'm still here. So I think it's something you ought to think about.
Right, and I think I'm almost certain Tagawa will talk about theranostics, lutetium-177, AC-225, but that's because it seems to be his expertise. As far as Mark Stein, I believe it is going to be about biotechnology and or CAR T cell.
But you haven't exhausted the conventional therapies yet.
That's right. Absolutely, Carl. Absolutely, Herb. Don't be looking at all these fancy stuff when you haven't covered the basics. You got to get these basics out. A lot of those trials, by the way, require that you've done chemotherapy first.
Yes.
Look at them. Go look at the trials and look at the requirements. And many of them will say you've got to have done some chemo, at least one round of chemo. You don't have to do, Ken's on his 11th treatment and this is his second session. You don't have to do that.
Right.
But you've heard it enough. Can we go to Rusty?
Right, I want to go to Rusty. That's what I want to do next.
Okay. Rusty, put your mic on.
Rusty.
Are you talking on your phone?
Rusty.
I think.
Hello, Rusty. Come in.
Come
I'm
in,
here.
Rusty.
I'm here.
Looks better.
So you're tell us, talk to us.
Well, first of all, tell us about speaking freely.
We caught you napping.
Sure. So Men Speaking Freely is the third Thursday of every month, which will come up this week. And it is men talking about things that men usually don't talk about, which is the emotional side of having cancer. It's open to all different types of cancer for men. And, sometimes we have an agenda, sometimes we don't, but it's really just getting together and talk about how cancer has affected us, how we're feeling now, what the future holds. And when that's all over, then we just start talking about women, motorcycles, vacations, whatever. But it's a great group. And when it says men speaking freely, it really is an open forum to tell us how you're feeling, that you couldn't talk to anyone else unless they were going through what we go through. So that's the short ad. You can go on to AnCan and get the link. But it's Thursday at 7, I believe. Is that right, Rick?
It's the third Thursday at 8 o'clock.
8 o'clock, okay.
Third
Eastern.
Thursday, 8 o'clock Eastern. Sorry,
Eastern.
8 o'clock Eastern. Sorry, guys. Third Thursday
And-
at 8 o'clock Eastern. And Rusty's a moderator. Rich Jackson, who was with us earlier, but I don't see him now, is a moderator. And John Ivory is a moderator too, who is with us. Next time you get to do the commercial, Mr. Ivory.
Actually, I'm not a moderator. I'm one of the moderators for under 60, but I usually
That's
can't
right,
make
for
it.
under 60. Quite right. I get confused.
I'd like
So
to make
Rusty-
it. I'll try to make it again one of these days.
Right.
Okay.
So Rusty, tell us about your medical things.
Okay, I just want to finish up with the one thing that we don't talk about is men speaking freely. It's not about like this meeting is, where you can talk about treatments and doctor's appointments. That's not what that group is for. We have plenty of those, that you can attend, and with experts, like Rick and Peter and others. But it is really just a place to let go, let your guard down, and talk about what's going on in your life, except for treatment. So I'll move on to just a real quick update, which it's not much, but nothing on cancer. I'm undetectable, which I got my PSA 2 weeks ago, which I've already mentioned. But I had a rheumatologist appointment today. I've been diagnosed early on, and we have more tests to do for lupus, and that's it attacks your joints and can attack your organs as well. So spent a long time with my rheumatologist today. I go back tomorrow for multiple tests, and so I got multiple blood tests, and then I think they're going to do X-rays and sonogram. And literally in the last 2 weeks, I've developed a golf ball size, I would call it a cyst at this point, that has to be looked at as well. Following up on the mammogram I had a few weeks ago. So it's been a roller coaster, but on the cancer side of things, I'm coming off ADT. It's been almost 6 months now since I've been on it. Still having issues with it. Kind of feel like I'm going through puberty again. But that was just an update. I promised Rick I'd let him know how the doctor's appointment went today, and it's inconclusive, but she knows there's something going on, and it's a tough disease to identify specifically. So I just have a lot of tests coming up, and we'll figure out what's going on. That's it.
Good, thank you. So Joel, tell us about your situation.
Yeah, I actually have a question for Carl, and I have a comment to make to the rest of the group. Carl, did I hear you right that you had a spot of prostate cancer in your right femur?
Yes, in the bone marrow in the right femur, and also by the 7th rib in the soft tissue.
Yeah, unless I'm mistaken about my body parts, is in the right femur below the hip?
Yes.
Yeah, correct.
And how far down below the hip is the spot?
I don't recall if they said exactly where, but
Okay, well, the reason I'm asking is at the time of my biopsy at NIH, when I had my biopsy, 3 bones picked out of my left iliac, the scans had found a spot on my left knee, above the knee, about 3 inches. And I didn't know that prostate cancer could go below the hips. So, matter of fact, I even asked the doctor who did the biopsy on me, could it be prostate cancer? He says, no, it doesn't usually go below the hips. So that's why I was interested in your situation. And I still have a positive PSA, but I don't want to discuss my case tonight because I am taking a PSA again in a couple of weeks, and I'll have a better story then. The other comment that I wanted to make is as some of you know, I'm a leader of a prostate cancer support group in Virginia. And one of my guys called UCLA a couple of weeks ago and got an appointment for a PSMA PET scan. And of course, Medicare doesn't pay for it yet. So they said, if you pay us the $3,000, which we charge for the PSMA PET scan, we will give it to you. And when the Medicare gives us the codes, we will refund you. So you guys may know this already. I can't make all the meetings, so therefore that might have been discussed before, but I just wanted to pass that on.
Interesting. That's interesting.
A couple of things that we did know that you can get that they're charging $3,000 still. So thank you for confirming that. But we hadn't heard that they were willing to refund it when the codes got done. So that's new information and important information. But as to your comment about prostate cancer not going below the hip, it's not common, but it's certainly not the first time that we've heard about spots in the femur. I don't think I've ever heard of lower than the femur, but we've definitely heard about spots. And there's probably other guys on this call right now that might have femur spots. Joe.
Yeah, I can say I did, and the right femur. So I don't know that that's a true statement.
Mm-hmm. Okay.
Same here.
So
that's right femur and left femur.
So clearly it is in the femur. So let me move on. Peter, you said you had an update for us before you have to run out and check your pump.
Just quick, I just got my results a few minutes ago from my blood test this morning. So my PSA is holding steady at 0.15 ever since the end of chemo six months ago. I'm happy about that. My local doctor here, the imaging center, called me the other day and said, you're scheduled for another CT scan. And I said, what the frick's that about? I just had one. And they said, yeah, you had one 3 months ago. And I said, I don't need a CT scan every 3 months. So I wrote to my doc in California. And I think for me, it's a question of too much attention rather than not enough. My doctor in California, who's been with me for forever, agreed that, even though the CT scan's the best thing they can do here on Maui, there's no need to keep doing it every 3 months, especially if your PSA is holding steady. Do you guys agree, or do you think I should keep?
No,
doing
I don't
PSA?
think you need. I don't think you need it, but I think they want to do it because they make some money.
I guess so, yeah. Anyway, I'm gonna meet on the phone with them Wednesday and tell them I question it.
Okay.
We are all, first, I just want to say, Peter, I know Len and Herb and everybody, we're so happy the PSA is holding steady. And, it seems like that chemo nailed the peritoneal mass, whatever it was, floating around down there. So that's just great news. We love it.
Right. Yes,
Yeah.
absolutely.
Yep.
So
Congrats, Peter.
great, Peter. Thank you. I'll move on now. John, Ivory, you have something to share with us.
Yeah, I've got a quick question. So I think I mentioned that last November I had my first testosterone test ever after 9 months of Lupron and 8 months of Abby. And my PSA was great. It was less than 0.01. But I went to get another testosterone test. Oh yeah, and then it was the day I got my Lupron shot. So we thought that perhaps it was at the end of the cycle, so maybe my testosterone had gone up. But I went for another test on January 4th, and it was, did I tell you what it was? Maybe not. The testosterone was at 49. So I went back on January 4th, got the testosterone test again, and it was still 41. So my question, my doc didn't write to me or anything saying it was a problem, but I'm just wondering, everyone else seems to have theirs down around 10 or 12 when they're on these drugs. I'm wondering if I should ask for stronger drugs or what my options might be, or should I even worry about it? I mean, it's under 50, but it still seems a little high, and I know I only get 2 years that I'll be likely castrate resistant.
Ken Anderson is the man for this one. You there, Ken?
Yeah. You know, John, 50 is not where you want it to be. I mean, have you had 2 recent tests? Have they both been around 50 or 48, 49-ish?
No, the first was 49, the second was 41.
Oh, that's still high.
It's still quite high. I think today, that 50 numbers from, I have to say, like the 60s. I don't know if that's quite, I mean, it's an old number. I mean, you want it to be below 20 for sure. And are you on Abby at the moment or just Lupron or something like that?
Yes, I've been on Abby for 8 months, Lupron for 9 months.
So that's
You should be down below 1.
right. You should be undetectable. If Abby and Lupron are working, John, you should
really?
not.
Testosterone should be undetectable?
Yeah.
Yes.
Wow. Okay.
Those drugs should be blocking testosterone synthesis, and if they're not, then you have a biochemical abnormality that needs to be investigated.
Okay.
Yeah, I can send you my chart, John, and you can see from when I was on Lupron alone, when I added Abby, it's distinct. You lower, I mean, I'm below 1 at the moment. I have been for the last 12 months. So, yeah.
I mean, my testosterone on both is undetectable.
Okay, good. I'm glad I asked them. So I'll send a note to Morgan.
Let me just say that a lot of times people do get results by switching the LHRH drug. You're on Lupron right now?
Exactly.
So, and you just got a shot for how long?
I got one in November, and I was 6 weeks into it when I had the 41. I'm on the 3 month. I'm on a 3 month Lupron.
So you just got a 90-day depot today?
No, I got it in November, but then on January 4th, I had the reading of 41. So it was about 6 weeks into the 3 month depot.
Okay. So I think that it would be really good to speak to Dr. Morgans about possibly switching and seeing if another LHRH isn't more effective, and she'll be on top of that. Maybe to go to an agonist rather than to an antagonist rather than an agonist might be a good idea.
I mean, it might even be good. Even this new oral drug might be worth considering. if you can get it in insurance.
Yeah, if you could get it in insurance, it might well be. And you know what? Maybe we can even help you because we know some people at Myovant. If she thinks she would like to try it and she can go to bat for you, we'd also be willing to go to bat for you with Myovant. They may be, a lot of times early on, these drug companies are willing to cut deals to get people to use it so that they get experience. Like, for example, with Peter and Len and darolutamide.
Any of us I mean, I am surprised for another reason, and that's because Abby should do it by itself. It is such an effective enzyme inhibitor that there are people talking about just monotherapy with Abby doing it. And that is very surprising to me, John. But I think you need to talk to Alicia and see what's going on.
Yeah, Herb, I'm one of those guys. I'm Abby alone at the moment, no Lupron at all. And my testosterone level stays right around 1.
Yeah, exactly. So,
this is one of the big reasons why we encourage guys to get their testosterone checked, because the doctors don't, a lot of even the really good docs, they don't do it. And they say, well, why do we need to do it? Well, John Ivory's a good reason.
Right. So look, John, go get you're tested. I think we've got a few more guys that I want to get in tonight.
I'm on it.
Ken,
thank you all.
Ken, we'd like your update. Ken Anderson.
I don't have an update, Herb.
Oh, I thought you did. I checked you up as if you did.
No, I just wanted to let you know I was here. No, I don't
Okay.
have anything new. I have my 12th round of chemo on Friday. Everything's good.
Okay, great. So, Jimmy, tell us what's up.
Hello. It's been interesting tonight. I'm glad to see everybody. I got a coronavirus vaccine this morning. I thought I had pulled a muscle in my arm until I realized that it was probably soreness from the shot. But other than that, it was nothing to say other than glad I got it. I hope everybody gets it.
Which one did you get, Jimmy? Pfizer or Moderna?
Pfizer. I got it through Johns Hopkins, so I didn't have to wait in line or anything. It was very fortunate.
But if you're a Johns Hopkins patient, you can get it?
They got it to me through Sibley, and you know Sibley because you're from down here. So
right.
It's affiliated with Johns Hopkins, so they put me on there, and they had lots of appointments available.
Wow, I should
call. People are trying to get it through the city, and it's terrible,
Right. I mean, I can't get one here either.
Yeah. Well, membership has its privileges, I guess. But I feel bad for everybody trying to get one through the government right now because it stinks. Anyway, at Rick's urging, I did get a second opinion from a Dr. Zibelman, can't remember, at Fox Chase in Philadelphia. He spent some time with me on a telemedicine appointment. Very personable guy, very knowledgeable guy. Told him the whole situation. He proclaimed that I was in a data-free zone and that someone who had, I mean, that was his saying. And when I got through with all the questions, I like I said, I don't want to talk about the situation over and over again because, we had a lot of guys, but as far as stopping at a year, instead of going to 18 months or 2 years, 2 years was the original in the trial. 18 is what they told me I might do at the beginning. And this turned into a year. I said, after all this, I said, well, it's classic quality of life versus standard of care situation here. And I've listened to a lot of what people said tonight, by the way. And I don't want to die of metastatic prostate cancer either. And what I always joke about to my retired doctor brother is gallows humor is that I'm short on comorbidities. And I take such good care of myself otherwise that I'm cruising right for that. So one thing I did get also was a DEXA scan though. So I just to wrap up about the second opinion, I said, what would you do? And he said, I would do what you're doing. He's a young guy, but he said, I understand why you're doing it and I would do it too. And it's definitely controversial, I had a whole lot of adjuvant treatment. I had the kitchen sink, and I was deemed young enough and biologically healthy enough to handle the kitchen sink, and they did not hesitate to throw it right at my head. And it's been rough, you know. It more looking back than when I was going through it. I tend to be able to go through things pretty well, and afterward I say, wow, that was something. It's just my nature. But anyway, it looks like I'm going to continue on, and I won't be getting, you know, nervous or whatever. I don't know until first PSA and testosterone after this will be in first week of February. I got a DEXA scan though, and it kind of reinforces what all of us know about this. Now, my exercise habits, I would purport are second to none for somebody my age. And I mean, I lift, I do aerobic exercise, I do a lot of things, and I work really, really hard. And despite that, after a year on Lupron, my T-score, and I don't know if these numbers mean anything to some of you they do.
Yes.
It was 1.5 when I started, which is very good, and 1.5, and it's 0.8 after a year. So that's a drop of 4 or 5%.
Well,
but
it's
I
not
did have a good
negative.
baseline.
It's not good. It's not negative, so that's good.
It is. I started with a lot, so I was able to lose some off the top. And my visceral adipose tissue went from 22 to 60.22 to 0.61. So that's getting into a little bit of a higher range. I mean, I'm not saying it's bad. Again, that's not bad. That's not in the high range, you know, but my body fat 20.7, it's gone to 26.3. Again, because I'm a pretty athletic guy and those numbers are, I understand, good for somebody my age in either case. Fact is that I really bore down and tried to work as hard as I could on the diet and exercise through a year of LHRH, and I still end up getting fat. I still end up having body fat around me. My T-score still dropped, bone density dropped. So it just shows you the Lupron, you know, and Eligard in this case, can sure do a number on your body. And yet, you know, I still feel ambivalent about getting off of it. I'm still a little nervous, but I kind of feel like I just want to find out while I'm still relatively biologically young. And, you know, that's kind of where I'm at.
Okay, thank you. So, Dennis McGuire, you would like to share with us?
Yeah, thanks, Herb.
Dennis, hold on one second. Herb, do you just want to explain to the guys what a DEXA is for those who don't know and why they should get one?
Well, I would assume everybody who starts on this journey gets a baseline DEXA scan.
They do not.
Herb, I gotta tell you, I got one on my own volition. It was never mentioned by any of my doctors, urologist, oncologist, anybody.
Right.
I have a friend who's an athlete who suggested that I get it, and that's why I got it. And now, since then, I've heard us talk about it on the call.
Wow. I mean, the very first day I got diagnosed, they sent me for a DEXA scan. They signed me up for a DEXA scan. It's a bone density scan. So basically, your bone density depends upon hormones. And if you take testosterone away, you're losing bone density. Well, Jimmy, are you on any supplement other than calcium? Are you taking calcium?
I take calcium and vitamin D, and you know, I lift quite a bit. But
what about
what's that?
Are you getting any injections of anything for calcium balance?
No.
Okay. Well, some of us are.
Yeah, and don't forget the DEXA scan also measures your body fat and your adipose tissue, so
well,
it's that way too.
Mostly for me, it was just numbers about bone density. So we're all going to lose bone density. I mean, so I think a DEXA scan can tell you where you are, and if you're in the negative range, as I am, I already had a bit of bone loss, and so it's clear it's going to be a fight, because if it gets too low, we're going to start to see fractures. So it's really important to know that, because there are things you can do to hope to treat it. Calcium, other drugs that interfere with bone that modify osteoclast and osteoblast metabolism. Lynn, I forgot the name. Maybe you remember.
Fosamax.
Right. well, Fosamax, not only Fosamax, there's other drugs as well, right?
Yeah.
Well, Xgeva is one.
Right.
Zoledronic acid, Zometa is another.
Right.
Yeah.
So there are a bunch
I
of them.
was saying, I told my oncologist that I had taken it, and that was 0.8 after a year. And he said that that was very good and that I did not have to think about taking any drugs.
Right, right. So, you know, I was kind of the poster boy because fortunately my doc did tell me to get a DEXA scan very early on when I went on hormone therapy, and I was osteoporotic, and I couldn't believe it because I was running, I don't know, 2,000-3,000 miles a year, and I changed my exercise habits, and I was given 3 Zometa shots over 2 years, and I got my bone density down from minus 2.5 to minus 0.9. So
Okay,
you
that's
can
great.
do it. But everybody on this, and I just got retested just recently, and I'm still, I am still I have osteopenia, but I'm not as bad as I was. But
Right.
everybody,
So,
we say this from time to time, maybe 2 or 3 times a year. Make sure if you haven't gotten a DEXA scan and you're on long-term hormone therapy that you ask your doctor to order one, because the docs just don't think about it. And it's then really, how often, really important.
Excuse me.
I'm
How often would we repeat it during hormone therapy? Once a year or something?
I'm sorry, what was that, John?
How often would we repeat it during hormone therapy? Once a
Well,
year?
I would say,
Like that?
I would say once a year.
You've got to talk to your doc about this because there are different ways. I mean, now sometimes some docs will give you a Prolia shot. There's Xgeva. If you are marginal and you do not have bone metastasis, then they give you a much reduced,
right,
which was my case. They'll give you a much reduced dose. If you've got bone metastasis, then the dosage, the Zometa now, the common dosage is once every 3 months. And Xgeva, I think, is still given every 4 weeks or 6 weeks. I forget.
I actually got
Prolia is every 6
Meta
months.
for the year.
Yeah, I'm getting every 6 months, but I definitely am osteopenic. So, and I've supposedly, I need another bone scan, but they won't do it during the COVID situation. They're just gonna, they have to get over this first. At any rate, let me move on because we have a few guys left and we're gonna run out of time. Jeff, did you have something to share with us?
Yes. Well, I just started Abby last week. I went in I had 1 bone scan and 2 PET scans, the second one an Axeman. And there's this spot on my spine at L4 that they've been reporting as non-specific mixed lytic and sclerotic lesions for about 3 years. And the Axeman scan showed it was actually metastasis. And just a couple of questions. How long does Zytiga side effects take? My blood pressure went up like within 1 day, but I've noticed nothing else. Does it take weeks before you have the fatigue or the other symptoms?
Well, are you already on Lupron?
Oh yeah, for 3 years.
Then I think you're going to find the side effects in addition to from Zytiga are rather not significantly more.
Yeah, I'm a little bit warmer, but not much. The thing is, should I do anything about those lesions? What have people, I've been told by my doctor that since it's been 3 years I've had them, they really haven't grown, even though they're metastasized, that the Zytiga should take care of it and should stop it from growing any further. Do other people have any comments on that?
Anybody? Rick?
Let me defer to to one of the people that's on Zytiga.
Well, I mean, I'm on Zytiga, so I mean, I think my own sense is if the lesion is not growing in a scan, and if it's stable, then I think you leave it alone.
Yeah, that's what my doctor said too.
I mean, that's, you know, at least in my world, PSA is a surrogate marker, whereas they really are depending more on scans for seeing progression. And that's what they consider a higher standard. So if it's not moving and it's been there for 3 years, then I think I think Zytiga will take care of it if it needs to be taken care of.
Right. Right. Let's see now.
And,
Well, that was, I think, all that I had.
great.
I've been told by my doctor that getting a PSMA scanned at UCSF is pretty difficult. It may take a couple of months to get an appointment because they're so backed up. But within 3 or 4 months, it's going to be approved by Medicare for more universal use, and it'll be available in a lot more places. But since the Axeman scan showed what they needed, there's no reason for me to do a PSMA scan at this time.
Great. Okay,
Hey,
well,
Herb.
thanks, Jeff. Yes.
I think you skipped over Dennis McGuire. I think he got kind of cut off.
Did
Am I
he?
right,
I
Dennis?
thought that-
Could
Yeah,
I just
hey,
say
Herb.
something quick to Jeff?
John?
I'm still
Could I
here.
just say something quick to Jeff? The abiraterone caused me very serious elevations in blood pressure to the kind of consistently 180 over 99 range, and they're having a hell of a time controlling it. So I can see, I heard him say that he was starting to notice an increase in blood pressure. So
Yeah.
I would just say, keep a close watch.
Yeah, I do it every day. The thing is, my diastolic went from the mid 70s to the high 80s, 88 and 89 today. So but they tell me unless the systolic goes above 140, don't worry about it yet.
Well, I think that's not true. I would treat it if it got much above 130.
Plus it will go up. Mine went up to 180.
John, 180 is almost malignant hypertension.
Yeah, I'm in stage 2 hypertension, and I was a 127 over 76 guy before abiraterone. So keep watch.
If you're over 65, they say that anything from in the 130s is not bad. It's not abnormal. But my wife has been between 150 and 130 for the last year, depending on the week.
Well, I've been dealing with a cardiologist who's been monitoring my blood pressure, and he really because I'm at the Heart Institute, and he really wanted to get it down less than 130. So that's why we added another drug. So
That's
if
what I
I
was
would
going to say. You take a beta blocker or some other blood pressure pill.
Right. So I'm on two different. I'm on an ARB and I'm on a calcium channel blocker.
About 30% of guys on abiraterone get a blood pressure effect.
Right. So let me go back. Dennis, did I cut you off?
Yeah, no, that's okay. Thanks, Herb. Can you hear me
No,
okay?
it's not okay. Yes.
I'm speaking
Please,
through my
continue.
phone. Yeah, my microphone's not working. So I stopped my clinical trial last week. This was the glucocorticoid antagonist. I was on it 3 months, did not respond. So this week or next, I'm meeting with Dr. Morgans at Northwestern. We're going to zero in on the Arvinis clinical trial, which is the ARV110 drug. I think we talked about it last month as a group.
Right.
I just wanted to put out to the group question if we've learned anything more about that trial over the last month or so. This is the androgen receptor degrader. I guess they came out with their phase 1 results at the end of last year, which were favorable. So now they're moving to phase 2 in expansion.
So, I mean, I think phase 1 should have given them the toxicity, and now they're going to try to find the right dose. But I think, you know, if the results are favorable, it might be something worth trying. Anybody else, Len, would comment?
I'm only aware of one other similar drug claim several years ago, at least 4 or 5 years ago. It was a Japanese pharmaceutical company, and I forget the name of it, unfortunately, but they said they had an androgen receptor blocker that didn't just block androgens, but also degraded the AR androgen receptor, but it turned out not to be the case. I mean, I hope for Dennis' sake that this drug is somehow different and he has better luck with it, but I'm not aware of any changes. I haven't heard anything new about that drug in the past month, which I think answers your question.
Yeah.
So that I think it was Takeda, Len, all those years ago that had that drug. I think it was Takeda, and I think they trialed it, but it didn't show results, the results that they hoped. As I remember if I remember correctly, it was because I think it was a drug that Dominic was going to try. I
think it was galeterone.
Say that again?
Galeterone. Does it sound familiar?
Yes.
It doesn't.
Yes. Oh, you're looking something up. Oh, yes.
No, I'm not. It's up here.
Yeah. Oh, are you remembering that, or did you just look that up?
No, I remembered it.
Oh my gosh. See, guys, you got to all go on darolutamide. So, oh my gosh, yes, galeterone, that was it, yeah. I wanted to say to Dennis that I haven't heard anything more about it on a results side, but what I have heard, we've heard, is it getting mentioned more and more as a treatment alternative. That the concept of a drug that destroys the AR, the androgen receptors, as opposed to blocking them. And it was mentioned in the tumor board for the virtual tumor board for Bryce Olson by the doctors who were on there as being one of the alternatives for him. So it's getting more exposure. That doesn't mean to say it works any better, but we're hearing more people talk about it.
Okay. Well, I'll report back after I talk to Dr.
Yeah, definitely. And I'll try to look up what I can, Dennis, if I can find any more stuff on it.
Dennis, what was the other trial you were looking at that was a bispecific trial that involved a chemotherapy?
Yeah, that was also at Northwestern. Dr. Vanderweel is running that. It's called 446. So it's 4 is Fortis Therapeutics, and 46 I think is the target.
Mm-hmm.
Yeah, exactly, and it uses a antibody drug conjugate. But it's a form of chemo, so it comes with potential toxicity like chemotherapy would.
Well,
and very early. They don't have a lot of patients on it. That's what makes me nervous about that trial.
I mean, if you've got Dr. M's attention, I would discuss it with her as well. She's going to know all about it because she works right alongside Vanderweel.
Right. Yep.
And you can ask her for her opinion of comparison. So, yeah. And wasn't it a blood cancer chemotherapy agent that they were going to use it with?
Yeah, that's exactly right. Good memory. I think the chemo drug is used in lymphoma.
Okay. So I have somebody you can talk to who's very, very knowledgeable on the blood cancer medicines. He's a retired NCCN pharmacist. He's headed up several NCCN pharmacies around the country. So if you were to consider it and wanted to know more about the chemo agent, and he may be even smart enough to tell you what he thinks of the viability of the trial, happy to make the connection. He's one of our moderators for our blood cancer group.
Okay, good. Thank you.
Okay, thank you, Dennis. And hopefully we'll see some new results.
No,
Les, you had
one last thing
one
here.
more. Yes.
No, I just want to let Dennis know that I'll ask Paul about the trial. I'll just see what his comments are in regards to the trial, and I'll send them to you offline.
Okay, good. Oh, I have one more question. It piqued my interest when we were talking about testosterone. When I get mine checked, which is not every time, I usually register in the 20 to 25 range. Is that something I should pursue to try to get it down closer to 0?
My sense is yes.
And I second that.
Yeah, I think 20 is a standard that they used to be 50. Now they use 20, but lower than that would be even better. But I don't think too many doctors would be too upset with a 20.
Sounds like we need to team up on Dr. Morgan's chair.
Yeah, no, none of my doctors are concerned with a 20. They're like, oh, that's fine. That's below 50. You're castrated.
Well, but I don't know.
Dennis, could you talk to Alicia Morgans about AMG 160, because she seemed very enthusiastic about that.
Oh, yeah, that would be her top choice, Len. Logistically, it's a little tough. The nearest one to me is Indianapolis, which is 300 miles away. But yeah, I think that's right. That would be probably a top choice.
Okay.
I just want to make a very quick comment. We'll come back to it. It just jogged my mind. We have now found a source of funds for travel and accommodation for anyone participating in a clinical trial of any kind. And they will pay people who are earning up to 7 times the poverty level. And it's a sliding scale. We're going to be working with them. We'll be writing something up on the blog in time, but this all came to light on Friday. It's very exciting. They do not support medical expenses, but they do support travel and accommodation, including for your partner or caregiver for clinical trials. We'll come back to it. I'll mention it again when we're tied down. But it's very exciting.
So
yeah.
let's.
So Dennis, think about the Amgen 160. I would move it to the top of the list. I know that first couple weeks can be real difficult based on the trial with Tran and Melbourne, but I would move it to the top of the list. But I will have Paul comment in regards to the one you're on or thinking about.
Well,
Okay.
there are two there, Ken. The ARV110 and the 4FOR406.
Right. So Dennis, I think we'll definitely, you've got a bunch of trials to consider. So,
Yep. Thanks.
is it okay if we move on?
Oh yeah, of course. Yeah. Thanks. Thanks,
Okay.
sir.
Okay. Les, did you have something to share with us?
It wasn't that important. I think you just move on to see if someone else is more significant.
Well,
to talk
we have I guess the other thing is Mike from Florida, I never asked you if you had anything to share with us tonight. But other than that, Mike, are you okay?
No, I'll pass. I just came in. I'll pass.
Yeah,
Okay.
and Mike, I don't think you've ever really had time on this call as a new guy. So maybe come in next week, hang in at the beginning. You were here at the beginning, and we'll get to you as a new man so you can tell us your story.
Right.
And
Okay.
Les, we're not going to let you go because you do this to us every time. You say it's not very important, and sometimes it is important, like last time it was important.
Well, I was diagnosed about almost 8 years ago, Gleason 10. My PSA doubling time is about 6 weeks. I've been on various treatments, radiation, hormone treatments a few times, cryoablation, and so forth. Well, intermittent in there's hormone treatment I've been on Firmagon, Eligard, and Lupron, and so forth, and then off for a while. Well, I was just put back on Eligard in the 2nd of December, and well, previously every time I'd be on hormone treatment, it would really hit me as far as my endurance. And comparing to other people, it sounded like mine was always worse than anybody else's. But then I'd be off for a while, and then on vacation, hormone vacation, and it would be a little bit better. Well, they put me back on Eligard on December 2nd, and I was anticipating getting hit hard again, and my endurance was better than it's been for 8 years. And okay, what happened here? I know Len had a different comment. Don't look gift horse in the mouth, but my philosophy was if it looks too good to be true, it might be. So I was, is there something I'm missing? But I did get the test back just a few days ago, and the PSA was down to 0.1, and testosterone was less than 8. So I guess the readings say it's okay, but why do I feel better now than I have for 8 years? Not much. I still don't have much endurance, but before it hit me so hard that there were times I couldn't come up from the basement without resting halfway up. And now all of a sudden, my endurance is much better. I'm an engineer, and that just does not compute with me. Anybody heard of that before?
Well, there is one thing, but it's probably too late now. But when they put you back on the Eligard, the first thing that it does is it boosts your testosterone. And that was the reason why we said to you that maybe you should have had a buffer, because that surge in testosterone can cause damage occasionally. It's been known to. So the issue is how long that surge lasts before the testosterone falls. In your case, it's clear that the surge happened because you felt much better for it. but now your testosterone has gone down, which is what happens after the surge because of the way that the agonists work, these LHRH agonists work. So, you know, when I saw Len's response, I said to Len, well, yeah, he feels great because he had all that testosterone in him. It probably shot up to maybe 400 or something. But that wouldn't make sense if you're still feeling good when it's at 8. So I don't know. The answer is I don't know. And you know, maybe there's in the early days, I mean, for many guys, it takes a good 3 or 4 months before they start to feel the effects of low testosterone in their body. So it could be even that, you know, with the 8, it just, the body hasn't adjusted. It's not like a light switch. Is that right, Herb?
Well, I think, you know, it's clear that hormones take a long time to wear off because they act through gene expression changes. So yes, it could be that. But Les, I just wouldn't look a gift horse in the mouth. You know?
Yeah, that's what Les said.
Yeah, stop stealing my material, Herb.
Well, all right. Leave well enough.
I have the
leave
same
well enough
experience.
alone? Leave well enough alone.
Yeah, I can't figure out what the
my
problem
mother
is.
would say.
Les, I have the same experience with it, and the way I rationalize it is they're just not making the drugs the way they used to.
So, I mean, I think time is going to tell. I mean, it may take time in which you'll feel you'll get back to the situation where you don't want to be, but enjoy where you are now.
Yeah, well, I am, but it's been 7 weeks now, and I still feel that way. So I've just
I don't know. I would just be happy with it.
well, I'm happy with it. Yes, it's just I don't understand it.
May it
I just
continue.
feel if it's something I can do again, I'd be willing to do it, but I have to know what it is.
Right.
So Les, how much snow are you shoveling then, feeling so good?
Well, usually, or it had been, if I would go out with the snow thrower, I would have to do it in 3 installments. Well, the last time I did it, I was out there in 1.
Okay.
Wow, good. That's great. So,
Sound of youth.
So we're getting late, but we have one more. John McPhee would like to share something.
And Tony is still. Don't forget Tony.
I think Tony didn't. Tony, did you say you wanted to say something tonight?
Yeah, I'm still here.
Okay. Well, let's go to John and then Tony. John, are you with us?
Yeah, I am. No, I don't have anything to share other than I just looked on my health network stuff, and my testosterone was less than 0.4, and I'm on Lupron.
Uh-huh.
And so, I mean, good. I was just surprised. I thought that Lupron would kick the crap out of it. Now I'm coming up to my 4 months, another shot on February, and so far I'm feeling okay. I find that I have a lot of energy, but then at some point I hit a wall and it's gone. We'll see how I fare for the next 4 months. It might not be as promising as what I'm experiencing now. That's all.
Well, I mean, you and Les can enjoy feeling good on Lupron.
John, did you get in touch with the Florshams, with Marguerite?
Yeah, I did, and their doctor had taken him off that drug, and I looked at the side effects of the drug, and there's a 1% chance I'm going to get liver cancer, and there's a less than 1% chance I'll get brain cancer or have blood clots. And that's all to get rid of, it's all to get rid of hot flashes. No thanks. I'm okay with taking my jacket on and off. So that's maybe why that drug isn't approved in the States.
Uh-huh. Right. Do no harm
Yeah.
is the. So John,
Well, that's it.
Okay, so Tony, tell us what's up.
Yeah, well, I don't know who said that. Did you guys say you feel good? The guys that are on Lupron, did you say you feel good when you're on Lupron? Is that what I heard?
We heard two guys say that they're on Lupron and they feel good.
Well, I feel like, I feel the exact opposite. But anyhow, I'm scheduled for my shot of Lupron this Thursday, and then they'll also give me a shot of Exchiva. I'm on case because I'm on Casedex and Lupron, and this Thursday I'll get my shot of Lupron. Every 3 months I get a shot. I've been doing that since September of 2018. And the thing I was going to say, I think I want to ask my oncologist for a testosterone test, like you guys were talking about. And also, what's the difference between the PSMA scan and a PET scan?
A PSMA scan is actually a PET scan. So because what they do is they attach a radioactive substance to something that binds to PSMA. And this radioactive substance emits positrons. PET stands for positron emission tomography. And so the radioactive moiety is emitting positrons. So really, there are many other kinds of PET scans, but a PSMA scan is generally a PET scan.
Oh, okay. Because I had a PET scan, but that's been like, I don't know, that's been over a year ago. And I was, it showed that there was no, that I was in remission, that there was no cancer, supposedly,
Tony,
no red blotches. Go ahead.
But Tony, a PET scan is like saying I had a piece of fruit. It could have been an apple, it could have been an orange, it could have been a banana. PET scan is very general. It depends what type of PET scan it was. So a PSMA PET scan is very different to what you had.
Well, it was the kind where they injected me this radioactive fluid into my veins, into my arm. That's what kind it was.
Well, it may not have been radioactive. It may have been a sugar substance. Do you know it was radioactive?
No, they told me it was radioactive. That's what they said.
Okay, well, I think
because they had to order it, and they said make sure it was real expensive, and they said make sure you're going to be here now because we have to order this. But anyhow,
it was probably Axeman, I would guess.
Right. Huh.
Yeah. Yes. So anyhow, the other thing I wanted to say is, I noticed that all the side effects with Lupron, I'm having trouble with my getting my thyroid balance. And I just noticed, because my doctor, my primary care physician, just had to, hire it up. I'm taking Synthroid or the generic leva something. I don't know. The generic.
Levothyroxine.
Yeah, there you go. But anyhow, so he had to up it again. It was at first it was 50, and then it went to 75, and then 100. Now it's 100. Now 112. But anyhow, I just noticed that all those side effects that I got with this Lupron, like the fatigue and the weight gain and the brain fog, do you know that those are all the same side effects for whenever your thyroid isn't working right?
Right.
So
They're all side effects of hypothyroidism. So Tony, have they checked your thyroid function very carefully, looking at things like TSH, not only free thyroid?
Well, I just did the blood work for that, and that's and go ahead.
What was your TSH?
Well, they didn't tell me what it was. They just said that the doctor wants to up your levothyroxine up to from 100 to 112.
Okay. Tony, you have to get these results for yourself, and you got to keep them, because we can't help you or give you any insight if you don't share them with us. So we told you this before, you've got to get all your test results and keep track of them, because maybe we're onto something here, and maybe it's a thyroid issue as much as it is the Lupron, because balancing the thyroid when there's no testosterone in the body is a very, very difficult thing. But we need those. Right, but you're not giving Herb enough information here.
And I think you need to get these numbers. They should give you your numbers every time you get a test. You should get a complete report, not just your doctor, because you can't unless you have the numbers in front of you. We don't know what it is.
Okay, well, the only thing I was going by was that the doctor ordered it to go to take. He upped it, so it wasn't. I had the hypo where it doesn't put out enough of that. I forget what that's called. It starts with a T. It wasn't putting out enough of that, so he upped it. So I figured if the doctor looked at the results and he ordered it to go to take more of it, then that's what I did. But anyhow, the other thing, what I was going to say is about this. Here's the main thing. What I wanted to ask you was this here. Usually, when here's what usually happens. Like when I go to my cancer clinic, I get a shot of Lupron. They give me a shot of Exgeva. They do blood. They take blood, and then they call me like the next day, and they tell me what my PSA results is. Now, the only thing I want to know is why can't they do the PSA first before they give you the Lupron shot, or does it matter? Anybody got any thoughts on that?
I mean, the bottom line is they take the blood, you get the Lupron, but then they measure the PSA after you've gotten the shot, and that's very typical.
Okay. Well, no, I just want to know because
It doesn't really matter. It doesn't really matter because you're in a. Well, Tony, you want us to ask us or you want to tell us? If you want to tell us, we'll just stay silent. If you want to ask us, we'll tell you what we think. Now, if you want to know about whether it matters, the answer is you're in a situation probably where your testosterone isn't changing very much because you're continuously getting it suppressed. So it shouldn't make much difference whether they take the PSA before or they take it after. Certainly it isn't going to make much difference whether they do it before you actually get the shot or after you actually get the shot on the same hospital visit. I've never heard, I mean, I could be wrong, but I've never heard that makes any difference. Now, could make possibly a difference if this was the first time you were getting testosterone, getting Lupron, and then they measure, but by and large, it doesn't really matter. The bigger issue for you is to come back to what we discussed last week. If you're having a problem with the Lupron, which you are, because this is always what you tell us, then there are other alternatives. We suggested to you last week maybe trying something like monotherapy Casodex. Instead of taking 1 pill of Casodex, you take 3 pills of Casodex. That's worth discussing with your doc. It's also, you wanted to follow up with another doc, and I know that Peter sent you some information. I don't know if you and Peter have talked anymore, but we can only make suggestions to you, but we hope that you will follow through. because then you won't be complaining about the same thing each time. We have some great ideas on this call, but you have to implement them.
Yeah, I understand. Well, I was thinking about taking. I talked with my doctor about taking Zytiga.
And what did they say?
Well, they said it's my choice. I could take Zytiga and Lupron, or I could take Lupron and Casodex. But see,
What
we
about
haven't.
Zytiga alone? What did they say to you about just taking Zytiga?
They never said that.
Well,
They never
that's
said
because they're not experts in prostate cancer, Tony. If they were experts in prostate cancer, that would have been another alternative they would have offered you. Just like Ken Anderson is on Zytiga alone right now.
Okay, but could the other thing be that they don't know that the Lupron has quit working yet? That it's still working?
The only way, the one way we'll see if Lupron quits working is if your PSA goes up. Is your PSA going up?
No, and that's why I'm excited to get this PSA score this week, because the 3 months is like, it seems like it's 3 years waiting for that next
so there are
PSA.
There are two ways they can tell if the Lupron isn't working. One is your PSA will go up, and the other is your testosterone will go up. So that's why we always say to guys, measure your testosterone, because if your testosterone starts rising, as you heard with John Ivory, you've got to ask your doctor, why isn't it keeping it low? And it's a good thing that you're asking for your testosterone measure.
Okay.
I mean, basically, if your PSA is remaining low and your testosterone is remaining low, whatever drug combination you're on is working.
Correct.
So, as you know, again, if it's working, don't, if it ain't broke, don't fix it.
Yeah, but there's a quality of life issue here, Herb. And,
maybe.
This is the issue with Tony, that it's working, but he's having a hell of a time living with the loop.
Well, then I think it's maybe other drugs. I mean, there are antagonists that could be used.
Right.
Yeah. Yeah, because the brain fog, it's definitely
Tony,
for real.
The one thing we've said from the very beginning.
Lipitor just messed me up terribly when I was on Lupron.
And what did you switch to, Jeff?
I didn't need it. My doctor did it just because of my age.
Okay.
But boy, I could barely walk when I was on Lipitor. It was so bad.
Lipitor.
That's why I mentioned.
We're talking about
Lupron.
I was on Lupron, and they added Lipitor, which some people take, and that just destroyed me. Taking away the Lipitor, I was just fine.
Yeah, okay, but we're not talking about Lipitor here, so I don't want to confuse the issue.
If you're having the hot flashes and they're giving you a lot of fatigue, the Depo-Provera shot, I get one every 3 months. I get almost no hot flashes. I never get fatigue from it anymore. It was killing me before Depo-Provera.
But
I'm gonna have to ask him about that
Tony,
Depo-Provera.
Tony, I really think it all boils down to one thing. You need a GU oncologist who knows this stuff cold and not gives you really oddball combinations or gives you a menu. They should be able to explain to you your situation and what they recommend and what the alternatives are based on knowledge. And I think you don't have that.
Yeah, you're probably right. You're probably right.
And Tony, I would not worry about the thyroid issue. I think your doctor sounds like they have it under control. I'm up to 125. It's a balancing act. It's not something you can do yourself. As long as they're watching it and checking the levels every once in a while, and keeping an eye on it, it's not something it's a very fine balance. So you're okay.
Yeah.
Just
I
don't
understand.
take it. Don't forget to take it, because if you stop taking it for 3 to 4 days, you will feel it for sure.
Right. No, don't stop.
I know. And then the other thing is, they just found out I went to the sleep center and I got sleep apnea. So, I'm fighting some different battles on different fronts here. So there's a lot of things contributing to my fatigue and brain fog and all this other stuff. It's not just the Lupron. It's these other things that I'm fighting.
So Tony, I think generally it's getting late, and I'm thinking maybe we should continue this another time.
Yeah, I do. Yeah, I do too. Yeah. Well, I just wanted to thank. I always get a lot out of everybody's comments, man. You guys all sound like you're doctors compared to me. I mean, I sound like I'm like in preschool compared to you guys are like. I mean, you guys all sound like you're doctors. I don't know. It's just amazing, and I get so much out of this. It just blows me away. It really does. And anyway,
we appreciate that. So, gentlemen, I think, is there any comment from anybody that I missed? And so we will therefore conclude for tonight. We thank you for your contribution.
Thank you, Herb. Good job.
It is Martin Luther King Day, and I think we ought to think about the lessons that we learned from him today, and then Wednesday's Inauguration Day, so we have something to look forward to this week. So I hope everybody has a good week, and we'll talk to you next week.
Good job, Herb.
Okay.
Thank you.
Great.
Thank you, Herb. God bless.
Next Tuesday, guys.